So, if I may come in, so like she rightly said, it's virtually two different worlds apart. And even in that, there's another grading system. Those of us in the districts and those in the city.
Yes.
So the gap keeps on, dwindling. Oh, sorry, it
Wider.
keeps on getting wider as you step, lower into the less endowed facilities. So where I am, I think we're a little bit fortunate than other district hospitals because we've got the support of donors coming in. So sometimes we get some equipment for use. Regardless of that fact, we still have our challenges. I can remember one time, a donor came in bringing us, I think, incubators from Germany. Fortunately or unfortunately, the manual instruction was in German. Nobody around to really do the reading for us. Temperature regulation with babies in the incubator was a problem. In fact, at times you could actually virtually smell the babies cook. Until we had to get a German visiting. And we brought up the manual. We had to do some adjustments with a biomedical engineer from somewhere. And we were able to fine tune it. So these are some of the challenges. Because we're unable to really manufacture our own equipment here, we rely so much on those equipment. And these are some of the petty challenges that comes with it. Again, power fluctuation. The same thing, we got another one. I think it was an outmoded ventilator, as it usually is. Our hospital become the dumping place. Now, it came in and the power pots, I think there was an issue with the power pots. There is an European one and there is an American one. And what we had was apparently the European one, what we are used to. And for some reason, we couldn't use it simply because the voltage and other things, the specifications weren't, congruent with what we had received. So, in as much as we may even be so-called privileged compared to other districts hospitals, we still tend to have some of these challenges coming in. So the other time, like I was speaking with Dr. Asari, for instance, if our BP caps, it keeps on breaking down. We recycle it almost every three months. Why? Temperature gradients.
Blood pressure.
Blood pressure cups. Right.
Yes.
So new ones, because I think it has a very sensitive material, the bladder. The inflating bladder is made of very sensitive material. It's temperature sensitive. So depending on where it is stored, if it's not in a very good climate, you have to, you get it breaking down not too long after you started using it. So these are some of the issues that we've been having.
I take my stethoscopes and blood pressure cuffs back now. I used to leave them at my house. And I came back maybe 3, 4, 6 months later and it wasn't working. So now I take it back with me because I know the heat degrades it. One problem that has been a constant has been power fluctuations. So, the biggest surgery of my life, and I've been doing this since 1993, so post-residency, was when I was working at Morso, close to my hometown, at a relatively new hospital, doing surgery for something totally unexpected. It was a huge tumor, blood vessels, it was stuck to everything, and I was operating with an assistant who was not really a surgical assistant, who I brought with me. We thought it was a simple fibroid. We're going to take it out quick. And we open up and it's, oh my goodness, a huge, it's a benign tumor, but it clearly had been there for a long time. It was attached to everything. So we are slowly kind of taking things down. She's bleeding like crazy, but we have blood. And then the lights went out. So it was me, Crystal, and they quickly got it. They had a light, but so they had to go. Then somebody put the generator on, and then they tried to plug the lamp in. It wasn't due, but it was daytime, so we kind of managed until they did. But I was just like, oh my, it was nerve-wracking, and that happens a lot. It happened in Mankraso. It's happened in this other place. But kudos to the nurse anesthetists and the staff. They make magic out of out of stuff. They things that I bring a lot of supplies. Our hospitals throw a lot of things away that can be useful. Our suction tubing, we use once, we throw away. And they're like, oh no, we don't throw it out. And I'm like, how? Run bleach through it and do it again and use it. And their skin prepping procedure, it is like, wow. I mean, they will scrub and scrub and scrub. And I'm like, here's this thing, Sabra, why don't you use it? They're like, oh, thank you very much, but no. And I see why. No infections, So you adapt and you learn to listen to those who are here, that you can't bring your nice, clean, do it 3 times, wait 3 minutes and that, because infection control is very important. So I've learned to, stand back and realize that those who are here know more than you. Not all everything that we do is here, but also the suction cannons. For years I threw them out because I'm like, nobody's going to use them. So when I found out it could be used again, oh my, it's great. On our labor and delivery unit, we have an emergency table set for emergency operations. After 2 days, if nobody comes in, the table is broken down, everything on there gets thrown out. So once I realized that, I'm the picker of things. I have all the gauzes, all the candy tabs, I have everything. I collect them all and I ship them down. And it's very helpful. And the fact that they can use it is good. But this is simple tubing. That could be used here. We don't have to, I guess we could because it's been working, but that's stuff that could be made here. That would be, I don't know, would be a category 1 or 2 based on what our regulatory stuff from this morning was talking about. But the suction tubing, yes. That's something that we could do here. We make rubber here. We don't have to have a poor supply of things. I don't know about the cautery system, which fortunately most places that we go to have a cautery system. This is a device that cuts and coagulates. So it decreases surgery time. In the past, you basically had to clamp everything, cut it, and tie it with suture. Now you have a cautery system, and you can just kind of cut and go. And so, like that little device, that could be diathermy, that could be, I call it Bowie, but you guys call it diathermy. That's something that could be done here. And that one, I would think would be maybe a category 2 or something based on the stuff I'm thinking. Yes. So things like that. A lot of stuff is thrown away that could be reused. And I send them down and people are very good about using them, But the challenges that I see, the sheer number of patients that you guys see is just mind-boggling.
Yeah, so Thelma, I wanted, if I could come in.
Please do.
I wanted to talk about our equipment with respect to the number of clients or patients we see every day. Where I am coming from, attending to about almost 2,000 pregnant women within a month, out of which almost 500 are delivered, either spontaneously or through surgeries. So here in the case, you have limited infrastructure, limited equipment. If pregnant women attend a clinic in a day, you could see about 180 of them. And then we have about 3 BP machines to check for 180 BPs in a day.
Oh, wow.
Yes. So the machines could go off, and then we would have to invite the biomedical engineers to come and calibrate, and then for us to continue working.
Okay.
We could have fetal Doppler machines going off in times of offering or rendering care to our clients. So looking at the patient's equipment ratio is really a challenge to us down here, irrespective of where you find yourself. Being at a clinic, even in the hospitals, they tend to face all these challenges. We could have the best of machines, but one, the weather wouldn't permit it to last. Two, the pressure on the machine alone would break it down very much often. I quite remember we received some BP monitors some time back, which were very good, but they kept on breaking down simply because the pressure on each machine per patient ratio was overwhelming, and we could just not handle it. Sometimes you go through procurement as a staff, you request for equipment, and then we all know it must go through procurement processes and all those things, delaying. When you are fortunate to have people to come and donate, then you are good to go. But where there is no donation from January to December, what do? You must wait for procurement processes to be done. And we all know the number of months that could take. Sometimes when you are overwhelmed, you tend to go around looking for donors, which can help your situation. If you don't get the donors, what do? You must go around raising funds to procure BP apparatuses, to procure fetal Dopplers, sometimes ultrasound machines. We currently have an ultrasound machine which is broken down, and the only reason is that there is a part on it which must be procured, and we are not even getting. So the facility that attends to about 2,000 pregnant women in a month falls on 2 machines. The 2 ultrasound machines, one is assigned to general cases, which takes care of the breast, the pelvic, the abdomen, and all those scans. The only one assigned to obstetric keeps on breaking down because of the pressure on the machine. And it's sometimes we cannot do anything about it.
But who does the ultrasounds on?
So when you come to my facility, we have a registered radiologist who does almost all the cases.
Scans.
But when you get to my department, we have midwives that have been trained in sonography. So we have 4 midwives trained in sonography that they do the obstetric scans. So anything above the obstetric scan, we either fall on the radiologist or there is a general sonographer who does for the breast, for the lungs, and all those things. So equipment is our major challenge here. The weather is one, and then limited infrastructure. I would be glad to see an ultramodern maternity unit set up to take care of this huge numbers, so that even in taking care of your numbers, you are able to provide privacy and the respect you need to give to your clients. Sometimes because we are limited, you tend to use the little space that you have. The people have come, what do? You must attend to them. So if we have our infrastructure right, automatically our equipment will be good. And then we will improve upon the quality of service we are already rendering to our clients. So I think this is some of the few things I also have to share.
What do you have to say, Daniel?
Yeah, so what I want to also add to the equipment we also don't have, we have like limitation in things to help us make our diagnosis. So for example, somebody comes to the emergency and they come in with a stroke, because stroke is really becoming something now. So they come in with a stroke and you want to confirm, okay, which type of stroke is it? Because each type of stroke needs a different type of management for it. And they come and you want to know, okay, what type of stroke is this? And you don't have a CT scan to confirm the stroke and then how to manage it. So if you're in a district, for example, house in Obuase, where we don't have a CT scan, a patient comes in with a stroke and then you have to now send the patient to Kumasi to go and get a CT scan done before you can manage the patient. So it becomes a challenge. Then probably have to just stabilize the patient, then now talk to the relatives who might even think it's not even necessary. You have to now try to convince them because they feel like, okay, the patient has a stroke. Okay, would the CT scan you want to do, would that solve the actual issue? You have to convince them. After convincing them, now try to get an ambulance that will now take the patient to Kumasi to do the CT scan. It becomes a very long process. And we all know that for stroke, there's a timeline. Sometimes you have For some of them, you need, like an ischemic stroke, you need a particular timeline to do something for that patient. And with all of that, it's like the time is becoming a long thing. And then now you decide, take the patient to Kumasi and do a CT scan and come back. Sometimes, for example, you are the OPD and you want to see a patient, you are seeing a patient, and maybe the patient is vomiting blood. You want to confirm, okay, is there a bleed somewhere? Is there something? I want to do an endoscopy, I want to do a colonoscopy. But you don't have the things there. There's no endoscopy unit or anything for you to do your endoscopy to find out what is going on with your patient. So you just have to stabilize the patient, do what you have to do for the meantime, and then when the patient is now stable, now ship them to Kumasi to go and get the investigation done. So that limitation too is an issue. Yeah, so I want to add.
If I could come in again, taking care of, I'll be a little bit biased shifting to the obstetric side because of where I'm coming from. I'm a midwife. So taking care of pregnant women again, we all know we need to monitor their hemoglobin levels each and every time. Monitoring these things sometimes, just getting our HB meters could,
The HemoQ machine.
HemoQs could just give you the hemoglobin level at a point. But these are also limited. So we tend to have higher numbers of anemia cases. Very well. On the large scale, or the gold standard is just to go for the full blood count, for you to get your hemoglobin, for you to get all other parameters, your RBCs and the rest. But for you to get a full blood count also is a challenge sometimes. Because you could go to a facility and you have only one machine serving the whole facility. So if I alone, my department is giving about 150 clients a day. Other departments are doing same, inpatients are there. What happens?
Well, the HemoQ machine, I remember talking about having difficulties placed on you. So 92, when I was coming down to do an elective, I got a HemoQ machine donated, and I had medications. They used to give a lot of samples there. So I collected all these antibiotic prescriptions and stuff, and I was coming to Kolebu, and I brought them. I got to the airport, and that was when they used to be really crazy. So the lady goes, "What's in here?" I said, "Oh, those are my antibiotics." I'm bringing them. "Oh, so where's the itemized list?" So I said, "I don't have it." So what's in it? So she picks up the HemoQ machine. "What is this one?" So I told her what it did. And we were there, I remember, it was 3 hours. They wanted money, and I wasn't giving. So I had to be begged by my brother-in-law, God bless his soul, to give them, I remember it like yesterday, $5. The equivalent of $5. I mean, this is 1992, but to give so they could release the stuff to me. Because they weren't good. And they knew, I mean, I'm not coming to sell it. These are different. Sometimes they just put more onus on you. Okay. People donate things. My office tables, Professor Lee, and Francis and I had gone on a tour of rural clinics. And some of them, there was no place for patients to lie for these chip compounds. They were on a bench. So in my office, we changed the exam tables. And I remember asking my office manager, "Where are we going to do the tables?" We're just going to dump them. And I thought, this could be used somewhere. So I said, I could ship them to Ghana. But the logistics was getting my shipper to come, so I had to pay him. He came to get them, cost me $3,000. I shipped them here, and then getting it to the districts. But they came in a very grateful, but I mean, some of them were not in the best shape, but at least it was a bed that somebody could lie on. It was just going to be thrown out if I could afford it. The amount of stuff I'll bring to this country. Because if you go to the loading dock, they just throw stuff out. They fix the room and the color scheme is wrong, they throw it away. They're about to get rid of cribs, small cribs for babies. They're getting new ones, a whole bunch of them. They're about to throw them out. But I can't. That one, when you ship, is based on space, so it doesn't do. But I mean, the stuff that they just threw out. But those cribs, I mean, stuff we can do here. We can make, everything doesn't have to be bought. Sometimes I don't understand. Because we went to one place, I remember when we did the the program in Chedi, one nurse was like, oh, we don't have measuring tapes to measure the fundal height. And I was like, are you kidding me? How many seamstresses are in this country? A measuring tape to measure a fundal height? You're kidding me. So sometimes we are so gimme, 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 we don't even think outside of the box. It really is kind of silly sometimes, right? So when we went to that program, I said, we're here to kind of hear what you guys' needs are. And the first thing I said is, please don't ask me for a building or a car. Because people are like, well, we need a car. I know you do, but we don't have the means to. But it was very illuminating to hear the little basic little things that could make people's life better. You know, blood pressure machines are those. Dr. Lee was going to, gymnastics was, I want to give them something. I don't want to keep bringing blood pressure cuffs. I said, please take it because they break down, So please, bring more. They're not very expensive, but I don't know whether you guys can use the portable ones, because if you do, sometimes they go on sale and we can, buy some and donate. I don't know whether we can.
I think we use those ones most
Yes.
within our system.
Yes.
But I think even with that, there is a little bit of a challenge. Most of them, because of power fluctuations, rely on battery.
Yes, and the batteries were.
The battery used ones.
Yeah.
And again, for conditions like preeclampsia, where you want to get your BP right, otherwise things start going down the drain.
Yeah.
If the battery is weak or calibrations on the SFIG machine is wrong, that means you're not identifying some of the risk issues early, and thereby not stepping in time to save the situation. And sometimes the consequences are quite difficult.
So preeclampsia is when a woman's blood pressure goes up
Right.
during pregnancy, and the only cure for it is delivery. So a lot of maternal deaths in this country are from hemorrhage. So they deliver and they bleed out. And I was telling somebody, I don't remember, I think I've had one woman die that was a planned C-section who had a previa. And that was because when we did her surgery and she started bleeding, we were thinking almost like Ghana, she wants to have more children. Let's try this, let's try that. And we basically got behind in terms of blood volume, and she died. Since then, have not seen one yet. They will get very sick, they will do crazy things, but they do not die. Other than, they do not, I don't see it. When I was at Kolebu, every morning at rounds, somebody had died. Young woman. Young people, and this was 1992, and it saddens me to see that probably nothing much has changed. And so my interest in this program is trying to see whether there are homegrown things that we can do for ourselves, because I can send all the donated things that you want, but who am I sending to? My husband's hometown, my own hometown, maybe one or two places. But we have intelligent people in this country. We are the same people who go abroad and excel and work for these corporations. Not all of us can get out of here. So if you're here, you can make your mark, and we can also do some of these things. Everybody, Walmart, you may not have heard about Walmart is a big, billion-dollar stuff. It started as a small store and became a bigger thing. So you start out small, and we too can become big and do better for our population. I think we are just so used to, everything coming from outside that I have to give props to Professor Lee, because, I joined and I go, he can't be the one who's more interested in helping Ghana than us Ghanaians who are outside. And so, and I don't find that altruism in this country. People who are very wealthy here who have things that people just don't, and you find also sometimes the healthcare workers, when you die, we'll come to your funeral, but sometimes we just don't care. There's sort of an unfeelingness about it that kind of saddens you, but you get people who are just working very hard, and it's just gladdens your heart to see that. You see.
Yeah, along the lines, if I may come in, along the
Yes.
lines of would I say skilled, along the lines of biomedical scientists or our local engineers, I think we need them most. Why am I saying this? We had an ultrasound machine which we had bought on hire purchase, very expensive. But I think for some reason along the line, the probe, which is the most sensitive part of the machine, I think probably due to malhandling, it got damaged. So long story short, we couldn't use it anymore. But replacing that part, because of the specifics and because it wasn't manufactured here, bringing it in and other stuff, till date, almost 2 years, we didn't have any new ultrasound machine. But I was thinking, if it was engineered here, we could easily get on to wherever it was, manufactured. They could, get something new right from scratch and then probably replace it. So those are some of the challenges. We had to. Currently, it's actually in the storeroom. We are not using it anymore. We had to spend extra money, which would have gone into other essential other essential equipment, into purchasing another ultrasound machine. Also on hire purchase, though we finished paying it, thousands of Ghana cedis. I'm sure it could have been channeled elsewhere if we had our local biomedical scientists bringing up and being innovative to manufacture something which could suit our system. So the challenges are myriad, and we just need to hold on to it one step at a time.
All I can think about is, I left Ghana in 1979, and one time I came here, I took a taxi, and I swear that car was there when I left. So if that car is still moving 40 years later, they figured it out, it was still running. We can figure out how to make stuff. I mean, you think about cars, you see these cars around, and they're still moving. The mechanics, they take something, they put it in this, and so the brainiacs are here. I'm thinking about reverse engineering. I mean, China, they get the thing, and then they take it apart, and then they figure out how to make it. We could do the same. I don't know whether that's legal.
But sometimes our challenge here is with the raw materials and the resources to do that. Because I believe most of our people that are trained have the idea, they have the knowledge, but then we are limited in terms of raw materials or resources. Because I quite remember some group of biomedical engineers came to our facility, and they were able to fix certain things with, they brought their own, I don't know who sponsored it, but they were able to fix certain things that were down and broken in our facility, and then it got on board functioning. So I think people have been trained, their knowledge is there, but then the resources, the raw materials to use in procuring certain basic things, we are lacking here, down here in Ghana. So if we could put resources together, I think some of these little things the challenges we are facing in our facilities could be fixed internally.
I think it's a business opportunity.
Yeah.
For GBI, at one point we were thinking about, these biomedical, I don't want to say engineers, because you don't need to go to a 4-year degree to fix these things. Who can go and fix these devices? When something goes down, you have the electricians. Not all of them went to electrical school. They're an apprentice. They come over and they finagle it out. I think that's another business opportunity. All the parts are made in China, for goodness sakes. Everything. And sometimes you might not be able to make it at a cost. It might be expensive for now, but you might be able to get it from China or something and fix these devices.
Ghana Health Service has as many as 7,000 facilities. They employ 200 biomedical engineers.
7,200.
Yeah. And they're hard to get, very hard to get.
Well, they can only go, but.
Yeah.
So if you're Ghana Health Ghana Health facility, you must get there by a medical engineer.
Right.
So even if you have the money, which you may not, you can't go get somebody else to come and fix it.
So that is another challenge, the resources.
Yeah.
In terms of equipment, human and all.
And the truth is, people are very innovative, but I realize that the Ghanaian seems to be more proactive in the face of challenges. Look at what COVID did to us. We never knew where these ideas had been hiding all these years. All of a sudden, we were breaking down breweries, alcoholic breweries, into, sanitizer producing, facilities, gloves.
Really?
Yes.
Wow.
We were doing all this here. And I think
We are reacting, not proactive.
Reactive.
we are reactive, yes. As if we are not proactive.
Yeah.
And that's, I
You
think,
said
is a
we're
problem.
proactive, yeah.
Yes,
Yeah,
that I
yeah,
think is a
reactive.
problem. For instance, a very typical example, when it comes to innovations, in my facility, I spoke to you about it.
Yes.
Yes, we sat down, we had a quality assurance group. We realized the number of macerated stillbirths, that's to say, babies dying in their mother's womb, way before they even noticed or before seeking, medical attention for any intervention, was going on the rise. So we just had to brainstorm, and you'll be surprised, among a team of doctors, administrators, specialists, do you know where the idea came from? A senior midwife. She gave us a very simple innovation, this bottle, and 10 stones. Lo and behold, within 6 years down the line, we're able to decrease the number of the stillbirths that we couldn't identify by more than half.
But tell them what the thing was, though.
All right, so it's called a Paulina bottle. So usually, a mother is supposed to be sensing a number of kicks. That reassures the mother and maybe the obstetrician seeing that baby is doing fine, if I may explain it in lay terms. So, under normal circumstance, if you're not able to get up to a certain number, then it means maybe the baby may be in trouble. Right. So we had to devise very simple means. She came out with the idea that why don't you get a bottle, and instead of probably, already we were building this principle based on what we call the kick charts. We have kick charts. But these are illiterates. They don't have paper and pen. But at least they can afford bottles and stones, which they can carry with them everywhere they go. So if they're going to the farm, they can carry the bottle with stones in it. If they feel a fetal movement, they pick one stone and put into it. If they feel a fetal movement, they pick one stone and put into it. By close of day, they should have had at least 10 counts. Then we say your baby is doing fine. In instances where you don't get up to 10, report to the hospital. We've got results like never before. Luckily, the Ghana Health Service within Central Region was able to adapt. So we are actually, spreading this among facilities. And I think this is very innovative. We don't really need to think so much of what is being used out there. If we sit together and then do what we call implementation science, what is found within our locality, I'm sure we'll be able to brainstorm to bring out stuff. And that lies very well within your ambits. And I think if we partner with you with some of these innovations, we could scale much higher. For instance, I saw a phototherapy machine. That's beautiful. The cost of that, if we are buying it outside, I'm sure these innovations may come even way cheaper. And again, we have those who manufactured it right here. In case we have any issues, they can come in to really help. And again, I saw one there, Ayuba. Is it the Ayuba CPAP?
The CPAP, yeah.
Currently, we have modified one in a NICU, a neonatal intensive care unit, with just bottles and water. Yes. We just have to change the depth of the cord attached to the oxygen pressure. And it's just like the CPAP, and we are getting results. Again, $10,000 as against maybe 10 cities or 20 cities.
And you are cleaning the environment, picking up all those bottles.
Exactly. So I think the innovation really is innate. But like you're saying, we need to be more proactive.
Yeah.
We've been looking out for too long, but if we sit and brainstorm, we'll definitely be able to do it, especially if you're partnering with people like you.
Yeah.
Yeah.
I told you this morning about my seamstress who said, "Oh, please buy me, asthma medicine." "Oh, doctor, you're coming. Bring me this." And I said, "Oh, drugs are cheaper." "Oh, but the stuff in abroad is so much better." And I'm going, the ingredients are the same and it is cheaper. And oh, by the way, that medicine you're talking about was probably made in India, imported to the US. In Ghana, it's cheaper. So I'll give you the money, just buy it. I had to convince her. She goes, "Oh, okay." You could tell she wasn't too happy. She wants me to bring it. If it's from America, it's better. You know what's funny? Tylenol, acetaminophen. You guys have, was it Panadol?
Paracetamol.
Paracetamol.
Yeah.
Every time I'm coming, your father is a prime one. Bring me Tylenol. And I cannot convince my uncle that she has the same medicine here. He's convinced, no, it's better. I don't even buy the brand name, Costco brand, and he just is for America, and it's like, yes. We just think if it's from there, it is better. It's the same drug,
So talking about innovation, we tend to improvise a lot down here because we don't have the things to work with. We tend to improvise a lot. We improvise something where we realize that babies that were being delivered asphyxiated, babies that are not able to breathe on their own after delivery, especially those that are from the theater, cesarean sections. We picked one of our baby cots and then asked people to weld small cylinders and then we attach it to the baby cot so that once you transport a baby from the theater to the neonatal intensive care unit to be attended, it can take you about 10 minutes to transport the baby under the condition of the weather. So once we have those cylinder pots, we are able to fix oxygens to the babies whilst transporting them from the theater to the neonatal intensive care unit. Rather than holding the baby that is not able to breathe, and then you are worsening their case. So these are some of the minor innovations we are doing to help improve the life and care of the babies we are delivering. As Dr. Riley said, once we partner, we could find ways of doing it better. With the limited resources we have here, what can we do? Okay, we have come up with a CPAP machine using a bottle and a tea. Instead of having the whole machine, we have come up with a resuscitator using a baby's cot and a little cylinder pot, connecting it to the tube, and then we are good to go. So if we sit down and think about these
Where's
things.
the engineer? That's a good one.
Yes, if we sit down and think about these things, I think we can come up with a lot and better things nationally here which can help us do well.
Where's that medical student who was talking about clinical trials? That was you. See?
So I'm also thinking about the problem associated with sterilization. Because not is associated with the hospital patient. Usually we're worried about how sterile it is. So you mentioned the babies and the cylinders and the latest. So how sure are we that this is sterile enough and that wouldn't exacerbate that baby's condition?
Yes,
Sure.
because
So-
you accept that you
In
want to
terms-
do some compromisation.
Yes.
In terms of what? And when you're transferring the baby.
So when it comes to infection prevention, it is a whole lot of area we take very critical look at. These machines are in the theater setting, okay? And whatever is in the theater is sterile. So once baby is delivered, we don't bring out the cylinders from the NICU to the theater. It is already in the theater setup. So once the baby is delivered, it is moved from the theater to the NICU. And then it does not come back to the NICU without passing through the CSSD.
So,
Do you get me? So the only thing you also need to be sterile there is not the cylinder. For the cords, I can decontaminate it. For the oxygen, all those things, the pumps, we dispose them and then get new ones.
Once the baby delivers,
So,
it's not sterile anymore.
For
You're not
infections-
intubating them. If you're intubating, if you're putting the tube to breathe for them, then what you're talking about is valid.
Sure.
This is just getting them a little
Resuscitation.
oxygen
right.
till they get to the neonatal intensive care unit.
So for infection prevention, we have systems in place to check that. We mentioned we have the total quality management team that ensures that infections are brought down to the barest minimum. And then we have a sterile department on it who takes care of all these, and the theater checks. So for sterility, I can assure you some of these things, we check on them.
They're very
much.
strict, because
Yes.
I was in Deer and Kanta Hospital, and I had some baby clothes to go donate, and I think it was even a step-down unit. It wasn't even the actual AQ. I had to take my shoes off, and I mean,
Sure.
it was impressive. It was good.
Yeah.
Because, they don't have, if the babies get sick, the antibiotics and all the rest is very pricey. So they are very good about making sure that you don't bring anything in. And so it wasn't, oh, Madam from America, come on, please, take your shoes. So it was good,
Yeah.
Yeah.
Okay, so you see, before this kind of engineering can come out, the biomedical engineer will have to be aware of the problem. So what I suggest is that we should accept our students if we should place them on rotational internship.
Right.
You see, the current internship that they do is that they come to the biomedical engineering unit, and at that place, what they do is that they will go with the biomedical engineer to maintain the machine, make sure it is working, calibrate it. But when I mentioned rotational internship, it's like they can come to the theater for some time so that they can know the problems there. They'll come to the emergency unit for some time. They'll come to outpatient for some time. So like they will take rotation in different departments at the hospital for some time. So
That's a great idea.
The problems that are there. So if we will accept our students on rotational internship, they can know more of the problems.
Okay, so when it comes to rotations, the Ghana Health Service has in-service training unit where they take students. I know my ladies here have been coming around. Yes,
My medical
they,
students,
not only nurses, but they take
Biomedical
all,
engineers.
yes, they
Yeah, I
do.
think
My facility, my engineering
Yeah, they do.
department have them in
So
their
they do, right.
numbers. So they've drawn a schedule. They've drawn a schedule for them. They go for periodic maintenance. They go for, I am at the Shire Sudoku District Hospital, Dodowa. So they go for periodic scheduling, they go for periodic maintenance. And then at my facility, each and every day, the engineers keeps coming and asking, do you have any challenge? If we don't go to them, they come to us. And these are systems that have been laid.
so how come, this is Academic City, are you from Academic City, or where are you from? Okay, so Accra Technical, so
Yeah.
who are the people from your institution? Where are these biomedical people coming from?
So
This
Accra
gentleman.
Technical, you are fortunate to just be by the Ghana Health Service Regional Office. So I would like to direct you to the training coordinator at the regional level. So when you get there, your institution would go, I have students, and it's time for them to do their internship. There are laid down procedures for you to follow, and they'll be taken and distributed into the facilities.
Yes, they go on internships, but you see, the one they go on is they go under the biomedical engineer. And when you go under the biomedical engineer, he goes to see to the working of the machine and then he leaves. But what I mean, suggesting right now in terms of rotation internship is, like for example, a biomedical engineer will be in terms of the internship, will be at the limit, the theater, that is not directly under biomedical engineer. Then maybe the following week, maybe he will go to ICU. Then the following week, he will go to another one. I think that one will help us to do more progress.
Gentleman has had
So
a hand
well
up.
taken.
I'm sorry, sir, go ahead.
Yeah, so in addition to what I was trying to say, this is more applicable when it comes to the private institutions. Because I've had biomedical engineers coming to my office. I'm a laboratory scientist. So we help them understand the principles behind the machines and how it works. But in the government settings, there is this bureaucracy.
Yes.
Right.
That if you are not a medical laboratory scientist licensed, you don't enter into the lab. If you are not a midwife licensed, you don't enter into the midwifery department. If you are not a medical officer licensed, you don't go to the consulting
It's a
group
good-
and check the central school. So from where this is coming, they will basically go to the biomedical engineering unit, but it's up to them to take the advantage of following whoever is going to the world rounds to enter into those departments and see what is happening over there and then learn something out of it. If not, if you are going by
What they
this
do.
bureaucracy stuff, you will never learn anything. Okay. So, one instance, my facility, Panther Hospital, the midwives were complaining about their hemocube, and that it's giving them high values. The same person giving high value, the same person giving you low value. You could imagine taking care of about 200 people in a day or something, and you are using one hemocube. But then we didn't have biomedical engineers, so they will fall on their laboratory to see if they can calibrate these machines for them. Apparently, it broke down, so they have to now be coming to the lab for FBC, as you said. And trust me, coming to the lab for FBC, 7 psychiatric people, 7
Everybody
over there. Okay, so midwife will be crying. My people are not coming. Then OPD will also be crying. My people are not coming. Psychiatric people also will be crying. My people are not coming. Then we're also stranded. Okay, so though it's good what you said, but they do that is going to help so that if every morning they go, do you have any machine for us to check? They go and check, calibrate, or whatever they do, then everything is set. That one will be rather helpful.
So sorry, if I may quickly react to that. Along those lines, you're right. Bureaucracies are inevitable in some of these instances. But I think as a nation, it's time we have to be very intentional about some of these things. It demands consensus building. So the top in the classes, clinical head, biomedical scientists, they should come together. And then that plan, trickles down. So that when I see you, I know that, okay, the clinical team has actually given you the permission to be able to walk around the theater. Other than that, trust me, this bureaucracy,
ain't gonna work.
It won't. So those are the top. It will have to be from the policy building stage. This is what we need as a people. We want to be more innovative. How do we get it? Our people have to be, they are supposed to get exposed to the very elements of things that we use everywhere, in theater, everywhere. Okay, then we should be allowing them to at least rotate, even if it's like once or twice in a week. So that they observe, and then, because if you don't see, it never clicks up in
I
there.
also give you ideas.
Yes. And you're right, when they come, I usually see them parked at the maintenance unit. And they're only limited to everything electrical. Oh, the iron is not working, the fuse is blown, can't fix it. So it's just those basic stuff. But when it comes to integrating clinical stuff with innovations, it never happens. And I think it will need to start up there and then trickle down.
Well, talking about, I'm sorry, I was just thinking about how we like things from abroad. Well, why not? When our leaders get sick, do they go to our institutions?
No.
They do not. We have UMGC, that one. UGC, I mean, fancy. I walked in, I was like, wow. But when our leaders get sick, they fly themselves out. So why shouldn't we also want something from abroad? Because clearly, if it was something good here, they will stay here. It's politically incorrect to say, but I will, because I'm not from here. You can't get me. But anyway. But no, that's the thing. It comes from out there, you see. So it's always the case. They tell us do X, Y, and Z, but they don't follow it. I mean, it's good for you, but when it's my turn, off we go, you see. And so it trickles down, and that's the problem. I'm sorry, sir.
I also want to say this. You made mention about biomedical engineers fixing fuels and other stuff. I think we are sometimes being misinterpreted in hospital. Sometimes maybe they come around, other condition is
They think you're an electrician.
Yes. So I think there should be a very, very clear difference between what an electrical engineer is and what a biomedical engineer is.
Yes.
We don't fix fuels and air conditioning.
Now, I sure hope the electrical engineer is not the one fixing the air conditioner. That one my local electrician can do, please.
So I believe in stakeholder meetings, consultations, and advocacy. Okay, so the challenge of the students going to the various facilities, I want to believe that before they go, they are set objectives that they must be able to achieve before the end of their intentions or rotations. In as much as we are managers, how often do we also follow up on them on the field? Because we could have people coming on the field working for about two months or more without their supervisors being there. So how well do we follow up on such people to ensure that the objectives that we have set for them to go and do, they are doing them? How well do we go to the various facilities to ask, to see their schedule? I think once we do these things, it will help correct some of the things in the system. You can equally engage the service. Your institution we have management meetings, we have quarterly meetings. Your institutions could get to the service, write to them, to be given the opportunity to also present at such forums to the major stakeholders, the major policy makers, and it could help change some of these things. For all you know, somebody has not even come to terms with this to ensure that people should be able to be rotated around the hospital setting where their services are needed. They don't know. So you can bring a change. You can involve yourself in management meetings. You can write to them to be invited to project what you have. And then from there, we take it from there, and then it will be good.
Would they let you do it? Is a question.
So
I mean, I grew
writing.
up in this country where you don't speak back, right?
Yes.
You don't speak back,
Yes.
and you know, sometimes my kids will. Dr. Lee knows one of my daughters, and she's as loud. I mean, and sometimes I have to check myself. I'm like, okay, they can say this, so you don't question, you don't say,
Yeah.
you know. So sometimes as a student, they may want to, but if you go and open your mouth, you know, the heads up may think, you know, an insolent, whatever. There has to be that people are allowed to do it. I mean, talking about innovation, they're not just going to fix instruments, but if you get ideas about things, the only way you're going to know about ideas is if somebody's walking around and seeing things, that may spur, hey, I could do this, you know. But if we don't, I mean, how often are you going to have an expo where people can come and talk about our problems? But I think that's a wonderful idea about going to the different places if they will let you, if the bureaucracy will let you, or even the private hospitals. You know, now every corner has a hospital, like the churches.
They don't
So
They don't have most
They
of
don't.
the facilities that their people need to go and explore. But I believe in writing. You want a change. You have a change idea. I believe in writing. Put the thing in writing. Put it on paper. Channel it through
You mean on
the
a
right
computer?
process. Yes.
Computer.
Email them. Channel it through the right processes. Go through. Once you push and push, you definitely get there. We tend to, I'll talk about it, but if it is not on paper, if it is not mailed, if somebody does not read, it's difficult for changes to occur. So keep on pushing. Keep on sending to the right processes. And you see, your people will do very well when they go.
I think the reason why they are fixing the air pumps and the fans and the irons
they're not doing it.
is because people have the mentality that they are working in the hospital and it's a biomedical
Yes.
facility. So far as
Every
iron
equipment.
is there.
Every
You must do
equipment.
But when you come to my facility, we have the estates. We have the estate managers who takes care of the lights.
But your facility is different, too.
And it is a district hospital, but you
No, it's a
see,
district hospital. But you see,
Yes. You're in town.
there are people that I meet. There are people who have a very different mindset.
Okay.
You know, my cousin Akuya is one of those. You are, you know, that Ejekum is one. The rest of the people that I meet, sorry to say, don't have that mindset. The woman who said, we don't have tapes to measure funnel heights. That one killed me. How many tailors and things are here? You can go and buy the tape. You're on the rural grade. You're watching us to come and give you a tape measure. That's just not thinking in the box. Everything is gimme, gimme, gimme. There are things you can do for yourself to do a little something. And I do not know whether, you know, sometimes I think they just go because, oh, let me just go, versus they don't have the passion for doing certain things. So it's kind of as a job, you know, let me go do it and whatever. But there are people who really do care. And so your facility may be different, but I dare say not every place is like that. Way if a student came and say, hey, can I follow you to the OR and check something, you say, sure, this is what you do. Other people will be like, they'll put rank on you, you see.
Yeah, exactly.
You know, we, under the auspices of decreasing maternal mortality, the Kolebu unit was refurbished when I was at Hopkins. And so when I came down, and this a time when doctors in training were coming to Johns Hopkins Hospital. I knew them, they knew me. I came down to do an elective, and the rigmarole I had to go through to be allowed to step on the unit. I had to go and prove that I graduated medical school. Now, they had come to my place, mind you. I got my degree, it's in Latin, translates. 1 week to prove that I was a physician, to go and do stuff. Nothing you said will convince them otherwise. That's the kind of bureaucracy that went on. They had donated an ultrasound machine. At the time, it wasn't that popular. The nurse, the chief nurse, locked it in a room. No doctor could touch it. The only person who could touch it was me because I was coming from abroad and, you're ferrying me, so they let me touch it. People couldn't touch it. So they pulled rank over very silly things, you see. And so if you're coming from someplace, it was okay. Everybody else, you can't speak. Senior midwife, how dare you say anything? And so that's the thing. So you may be the exception. Other people need to also have the same attitude to allow the young people to come around. Because if you come around and you see, even you say fix this, fix that, or just follow you around and they see what's going on, that may spur some idea for somebody to come up with something small. And that could be the next big, I don't know, Elon Musk's electrical car or something. Yes, ma'am.
Thank you so much for all this opening up. I think for biomedical engineering in Ghana, it's kind of some, sorry dog to, I'm not that ACity. Anytime dog is saying, you say biomedical science, biomedical science. So all the time, even when we are at the facility hospital, they always confuse us with the biomedical scientists. Biomedical engineering is very broad. As soon as we found ourselves in the hospital system, we are considered as clinical engineers, and we are there just to maintain the medical devices. Now, the challenges in Ghana, from my side, is like from the up to the bottom. The actual issue we are facing is from the top there. The Ghana Health Service, the Ministry of Health, said, it's not true the whole Ghana, the employment rate for clinical engineers is 200. Me, I'm against it. But the truth is, the data he has there is 200. And we've been asking we should take a data, and then like, who is to take the lead? Just recently,
So there's more than 200?
Yes, they are. Some of them are not from biomedically trained, they have other field. Now, and I also don't know why, even some district hospitals, there's no biomedical engineer, and we've been complaining since. Since I came up over 2-3 years or 4 years down the line, but the government is not ready to recruit. So doctors and nurses, the front line, I think there's no engineers in the country. We have plenty of them. Most of them now, they still want to find their way to survive, so they venture into marketing, sales engineers. So there are a lot of sales engineers in the market trying to bring in more, I don't know whether unauthorized medical devices or whatever into the country. They are making their profit. That's the only thing they can do to survive. And two, we have a lot of Ghanaians that have the ideas, the innovation, they are designing things. But currently what we are struggling is we don't have an incubator, let's say research center, where students, researchers, scientists can walk in to say, this is my idea. I've maybe prototyped it. Is there a facility, government hub or regional base that I can even come there, get all the laboratory things I need so that I can really improve on the phase 1 to phase 2 to see if there's nothing like that.
Dr. Yuboro was talking about there's something like that in Nigeria.
They have, they even have a license.
Yeah, he said there was something like that.
Even students' projects is still a problem. Students may have an idea, but if you look through around, if you skim through our Ghana, where can I recommend for this my student? Sometimes you go around, we write mails, we even do follow-up, nothing comes up. So I have to advise the students. If you want to graduate, graduate, put this aside because you will start, you won't end, and it will affect your project grades. So it's a big problem in terms of the research and then the resources, as Madam said. The raw materials are here, but the processed material that we need to is a problem. Now, when you want to venture into the sciences aspect to research talent, I think I have falls back on Mount Pond Research Institute, Nukuchi, KNUSC, I think FDA could have sent a sample there before. Sometimes I think they are in another world. No, they are not in academia setup. So their output they are giving us, it doesn't fit in. So when we go there, we pay huge money, but the report they will give us is not meaningful, and we have nowhere to go. We've even tried taking samples outside Ghana before, but take longer time, it will come and a whole lot. So for the technical brain, whatever we have there, I know students who have engineered things that even some of them are, even though it's not approved, but they are trying to do their own, trials, piloting in their own setups.
So talking about that, would the Bio Innovation Center serve the purposes that you're talking about if we're able to scale up?
Exactly, if you are to involve. And then how I wish if this discussion or this conference, we have clinical engineers in our midst. I realize none of them are here. We have no clinical engineer for none of the hospitals. And it's not, but they have the idea, they all know their problem, but it looks like even the facilities that they are, they don't have the voices out. When I meet them and they are talking, they don't have the when they speak, they just like.
I told you.
That's one problem they are facing out there. And then talking about the rotational, whatever. Yeah, I don't know if it is Ghana Health Service that rotates the management or whatever. I think in the Ghana Health Delivery System, the organogram is not permitting them to. Because I have gotten the opportunity to be rotated and through facilities, during my interns or voluntary that I did elsewhere. But in Ghana, it's held no. And the engineers too don't know that they have the opportunity, or they have even that opportunity to even approach their topmost managers to request if that opportunity can be given to their students or the people that come there. So obviously they go only a morning rounds and then they are there. Or they can just be on only one ventilator the whole day, or sometimes the whole week, fixing, brushing, meanwhile there's no job. And the other jobs are lying there, but they're not able to fish out to do. So it's a whole lot of things. So how, I don't know if this consortium can also help to dive into, if you can bring in regulations through Ghana Health Service, Ministry of Health.
No. When you bring the Ghana, if you bring those bureaucracies in there, you won't get anywhere. You won't. If you bring them first, you will not get anywhere. You kind of have to do. You have to do. I think it's like that anywhere. Private industry, I think, is more innovative than the government. It is true that government is the purchaser of most things because this is just the way our health system and things are. But if you're trying to do something and you go to them, it's not in their interest. First of all, the procurement person, he doesn't want whoever is procuring things. We all know what the deal is. He wants to buy his things so he can get his little 10%. I'll say it. But they're not interested in you doing something. So you have to do something here. And then once it's good, I think then you let them see this is a good opportunity for us and start small and then,
Look, I think Madam Midwife says something which we can fix into what Madam just said. That, our heads in the facilities, one thing that they are afraid of is writing.
Right.
Yes. Reason being that if you say with your mouth, where is your proof? So when you write,
then there's documentation.
And you make a statement, probably when this is not done within a specific number of days, we can't work or we can't give out these services because they know that they are going to lose money. Clients are also going to probably say a whole lot of things about the hospital. They will swiftly do something about it. So when you write, I really agree to what he's saying. When you write to them, and we've experienced it at our end. I can remember one time our FBC machine was spoiled. We have 2 FBC machines. 2, just 4. And we're not able to run this test. And as a union rep, I told my boss, this is what I'm going to do. If you are not able to service or bring us a new one or even refer it for us, we are going to just tell them we are not going to do night shifts and weekend shifts.
Ooh, that's bad.
Yes. We only work Monday to Friday. And because they know that the weekends and the night shifts are places that people come in with emergencies and all those stuff, they wouldn't like people to talk ill about their hospital. They immediately work on it. So I think writing.
So blackmail is good.
Excellent. So I believe in putting it into writing, but it's not, sometimes it's not what you say.
Exactly.
It's not what you write, but how you write it. Okay, because sometimes you may be writing the right thing, but how you put it will make it sound pleasant and appealing for people to step in.
I think you all started with some challenges that facilities are facing. I was actually thinking through my mind, what was the role of management when you were projecting those challenges?
Okay.
Yeah.
Okay, so personally, from my end, my management is always on their toes, bent on giving us the best to work with. But as I mentioned earlier on, you see, most of the times, for them to give you all these things, they must go through processes. My facility, I'll tell you, a member does not stay on my director's table for more than 24 hours without being approved. Because he always wants the thing to be done. So when he even comes and he finds that your BP machine is not working, you are assisted by the machine, that's another issue for you. So he is always bent on giving us the things to work with. But he cannot go way above or aside the procurement processes, and that becomes a challenge. So you realize that we need to get this monitor, we need to get this scan machine, even filter Doppler sometimes becomes a challenge. My management is always ready and about to give you, even though they are always not enough. Because in a day, I'll need about 10 BP machines to work effectively. But the most I could get on a day is about 3, at most 4. At most 4. 4 BP machines to check BP of 180 people in a day. So you can check for about 10 and then it will start giving you false figures. Doctor mentioned that pre-eclampsia, you need to get your BPs right. So it will just be giving you high BP figures whilst you know that, no, this figure is questionable. So management on my side, as I was saying, when you come to our facility, we have the biomedical engineers and we have the estates. They have been separated and they are all functioning and doing their work very well. For me, I'll never sit by a machine that is faulty. We have inventory books. I'll fill and do on you and you come and do it. So for management on my side, they are doing their best. They are doing their part, just that they are also limited. So they are not able to give us all what we need. But at least the basics, we are getting them, which we need much more than that.
So Francis?
Yes, your question about students having a place to, machines to work on. So the consortium, 2 things. The consortium is part of Academic City of Eastern and Fort BI, and there's also, like the consortium members. We have a equipment inventory so that we know who has what, and then you can sort of get together and use that. I think that is still ongoing, so if you haven't sent yours, please send that in, so we know how to use it. The second thing is this. I think there's a seeding grant, about $100,000 worth of equipment that the seeding, once you get the grant, they've shipped it in, it has come in, and they're setting it up. So it has a whole list of equipment, everything that a lab person can dream of. It is very exciting. And so you can also, as a consortium member, have access to use it. So I think all those 2 opportunities are available for you. And if people are afraid of the ideas being stolen, please don't be, because the consortium is collaborating, right? We really want to collaborate. So we have access to equipment. I know Shree's lab, he's given access to stuff like, so everybody, all this are there that you can use. So I just want to make make people be aware of that.
I'm sorry, sir.
So I want to talk about the project. Since it seems you're part of the managerial board of the lower.
I'm a service provider. I'm not a management member.
She speaks like one.
I like advocacy, policy making.
That's great. Because I have a problem with that. In terms of those who use the machine. Sometimes the responsibility they give by medical engineers or clinical engineers are a little bit original. Why am I saying this? Let me give you some typical scenario. Okay, we know an nutrition conference. We know how it is. You don't come and calculate it in the morning, then you use it for whatever. But let's say one day you go, you tell them, oh, my machine is fault. Okay, how did you get done? I don't know how it happened. You know perfectly well that it's wrong. You can see that maybe the engine broke it, so you can't do it. But the nurse doesn't want to get into trouble, or the technician doesn't want to get into trouble. So like, I don't know. What about that? Or something like that. Let me give you something like that. Let's say this pulse
of machines.
Yeah.
My friend is actually trying to like mobilize some for units. They don't really come and
Yes.
they have done something. Something like that. Let's say you have one in that, then it's damaged. Then they expect a environment guy to fix it. But if you should look at the device, it can't be fixed. But they expect you to do it because, oh, you're an engineer, you went to school. How about that?
Yeah, you have a point there. So we are talking about the training here. I'm an engineer. I've been trained. I've been educated. But what did I learn? Maybe I'm not good at fixing the pulse oximeter you mentioned. I'm good at fixing the scan machine that is faulty. That is where I am good at. No matter what I do, I'll not be able to fix the oximeter. So we need to tap into the strength of our staff. We need to tap into their areas and then work towards that. So if I'm lacking, I'm a midwife. Midwives, I know we do a lot, okay? But definitely you find a midwife who is very much stronger at a certain area.
Mm-hmm.
So when you come to our facility, as a midwife, it's not every midwife that is everywhere. Let me quote. It is not every staff that is everywhere. So I tap and I see your strength and I put you there, you deliver. So I think that is one of the things we need to see and do. Once we know that we are good here, you can help the system to improve. Why not?
I did have to.
Yeah.
In the hospital settings, if a human expires, I say human expires like that, who is to confirm that the person is dead?
The doctor is there.
He will just say, this one there is no life in the person. So at that instance, you, in your field of work, you have the power to say, this one.
We can fix it.
Fix it. So just give reports or whatever you need to do to write on it. And then if they are expecting another one, you leave. And everything goes over. I think that's what.
Sometimes,
think-
sorry, please land.
All right. So I think most of the questions, especially the two scenarios that you provided, I think it hovers more on ethics, if I would say. Sometimes being forthright or being very candid with things, culturally, I think we are lacking over there. Mainly because of how we grew up. Hey, when I started, whoa, we know the next thing that follows is what? Punishment. So usually people will do some of these things to cover up. But I think as we groom ourselves professionally, we may have to really change our mindset from that. Because if it fails, before you know, if that information becomes very vital to the biomedical scientist, he would know that, okay, then I should be looking at a part which is broken to fix this, right? So I think that aspects would all have to play a part in developing it.
We must be
They-
responsible in handling our equipment.
I'll say something quickly and go. The thing that sometimes baffles my patients, they come over, I've had this belly pain for 3 years, and I've gone to this doctor, that doctor,
Yeah.
and I check and I go, but it's not GYN oriented. But what is it? And they are baffled when I say, I do not know.
Yeah.
They're like, what do you mean you don't know?
Yeah.
But I say, guess what? Well, it's been 3 years and evidently you're still here. You're not dead. So it evidently is not that serious. Sometimes, but I need to know what it is. Well, you've had MRI, CT scan, you've seen Dr. X, Dr. Y, Dr. B. I'm not the first person. None of us have found anything. It's probably a little muscle cramp, but it can be. Well, ma'am, there's nothing else. People don't want to hear that, right? So sometimes you just have to tell them, if you can't fix it, you can't fix it, right? We'll take the last one because apparently we have 5 more minutes. So if you can talk for 5 minutes, you can fill out.
Okay, so some of the problems with the biomedical equipment, they are difficult to fix. For example, when you mentioned the ultrasound, because they are working, most of them they work with sophisticated softwares. And now what a salesperson, what they do is that when they don't release their softwares or those parts to their biomedical engineers, so they keep it at their end so that they'll be coming in for servicing so that they can do this continual charging of fees.
Yeah.
So actually for Ghana to realize the full benefit of biomedical engineering, there has to be deliberate effort either through the private sector or the government to set up biomedical equipment manufacturing or something of that sort. Because the sophisticated machines, for example, about last 2 months, I was at all the major hospitals in Accra with my students, 37, Kolebu, UGMC, Rage, all of them were there. There are a lot of breaking down machines.
Kolebu is special, though. Have you seen that room? All the stuff in there.
So, and it comes with parts. And the parts is such that once it is not manufactured here, you cannot be able to do anything. So it's that the engineer doesn't know anything. For example, for something that has got to do with the baby kicking in the womb. For that one, we can do a simple device that can actually measure the pulse when the baby kicks and differentiate it from the heartbeat. And then you can know that it's a pulse. Those are simple devices you can make. But for the sophisticated ones, there has to be deliberate government effort, either through the private sector to set up a medical equipment hub or manufacturing or something. As you also said, the engineer is that because the part is not there and there's nothing you can do. For example, the probe probably will be working with the software, and the software may not be completely available because when they buy, they don't release it to you. They keep it so you can always call on them and they can charge you.
That's how they make money.
Yes.
They do the same thing there.
All the MRIs, all the sophisticated if you buy from Philips, you must always go to
the price to upkeep your machine sometimes is more. So we have an old machine now. When we looked at how much it will cost to update, we're like, just buy a new one. Because the price was, when you get to, and that's what they want. When it gets to a certain point, it costs you more for you to come in. So then now they release a new one. iPhones, every year there's a new one. They change something.
Next year, if you are repeating this event, we can maybe call on the government policy makers, like in terms of the parliament, the committee on health. Maybe we can invite one person.
You know them.
We can start from somewhere.
You know.
We can start from
Tomorrow, one of them is coming. We'll all jump on him. Anyway, so I think we've come to the end of our discussion. I thank you all very much for coming and your work.